Greetings, aspiring orthopedic clinical specialists. We're going to review our foot and ankle scenario over the next few minutes, and I'm going to give you some tips about reviewing scenarios. I'm a paper person, so I like to highlight things. So we'll go through the scenario together, and I'll tell you some key points that I identify as I read the scenario. When I'm thinking about answering scenario questions, or any question for that matter, but especially scenario, I think about three types of questions. There could be examination questions, differential diagnosis, prognosis questions, and intervention questions. So I think about the information that's in this scenario that's going to help me answer those types of questions. So when we look at this foot ankle scenario, we're told it's a 22-year-old female. Anytime I'm giving an age, I always pay attention to the age because there are certain conditions that I'm thinking of are more prevalent in certain age groups. So if the person's 82 versus 22, there are certain things that are coming to my forethought and certain things that I'm not thinking are going to be as likely. So we always pay attention to age. So this is a 22-year-old female. We pay attention to gender as well because gender, there are certain conditions that may be more prevalent in female versus male. So I want to pay attention to age and gender when we're presented it. And we're told complaints of bilateral medial leg pain. So right off the bat, bilateral pain. She started a boot camp at a regional Army training facility 3 weeks ago. So we know that we've had this bilateral pain. So bilateral pain, we should have some ideas in our head of what we're thinking of. And it was 3 weeks ago, and it's been worse since that time. So this is a condition that's getting worse. She states she had similar pain before. So that's information that's also important. It may not be something new, but it's always resolved on its own. And this time it seems to be getting worse. So again, something she's had before, so she's not far into it, but this time it's getting worse. We're giving her pain levels, which get up to 7 out of 10 with activity. So that helps me think about how severe this might be. And she talks about it as a relative ache, but it's localized to the medial side of the leg. That pain location means something to me. We should be thinking of certain conditions that are more likely with pain in that area. She's overweight. We're given a BMI. So make sure you know your BMIs because you may not just be told someone is overweight. You may just be given a BMI and you want to know, does that BMI mean that they're normal weight height or that they're overweight, because obesity may be a comorbidity or may be a predisposing factor to certain conditions. She talks about losing weight over the past year since she's joined the Army. She quit smoking 5 months ago. These are all things I'm circling or highlighting because they absolutely could mean something to me for a prognosis or a differential diagnosis. And then we're told, based on the report, you suspect medial tibial stress syndrome, which I think we all were from the scenario anyway. We're told that that's the most likely diagnosis. So our first question talks about theories related to the etiology of medial tibial stress syndrome. So this is more of a knowledge type question where if you read this clinical practice guideline, if you read literature, you'll be aware of what the current ideas are for certain conditions. And it's good to be up on those etiologies. So for this one, the choice would be C, the periosteal modeling to reinforce the site where it bears the greatest stress and inflammation of the periosteum due to excessive traction. That is the current accepted, most believed mechanism for medial tibial stress syndrome. When we look at the other ones, they may not be incorrect. You may look at B and say hip and pelvis weakness alters lower extremity mechanics. That makes a lot of sense to you. It's not the best explanation. This is a specialty exam. So you may look at all 4 options and say, I think all 4 of those are correct. There's one that's going to be better than the other ones. And as a specialist, you would want to know what the best evidence is. So for this one, again, the best evidence is that periosteal remodeling, even though when you look at the other options, they may be contributing factors to this, but they don't best explain the presence of this condition. So after that, now we're given objective data. So now we have objective examination. Always important to pay attention to this. Pay attention to time frames. If this is a week later, if this is the same day, because that can make a difference. This is on the same day. This is initial evaluation. And we talk about having medial longitudinal arches that have collapsed or that are lower, valgus position of the hind foot. So you should think about foot structure and what that potentially means to us. Sensation testing is normal. So that's great because now I'm thinking neurovascular structures are most likely intact. We have pain along that lower border of the medial tibia. And then we're given range of motion measurements. We have dorsiflexion, range of motion measurements with the knee flexed. And we have how many heel raises she could do. So that gives us a finding on strength. And then we're asked, presence of which of the following signs and symptoms support the diagnosis of medial tibial stress syndrome? And our answer here is going to be exercise-induced pain that lasts for hours or days after exercise. The other, presence of paresthesias, presence of pain with exercise that immediately reduces. Focal pain at the posterior medial border of the tibia. All those are not part of the medial tibial stress syndrome classical presentation. It's exercise that lasts after we stop. So exercise that stops immediately, that's potentially more of a tendinopathy type exercise. And paresthesias is not part of our diagnosis. And the palpation piece doesn't match either in terms of where we would have discomfort for medial tibial stress syndrome. So our next question talks about tibial stress fractures is a concern for this patient, which I think we would all agree. And it asks about factors that are suggestive of a stress fracture. So now we have to know, we have a potential stress fracture. What are we going to see in the clinic that would raise our index of suspicion to us thinking a stress fracture might be present? We have a focal area of pain, frequency of exercise, pronated foot postures, symptoms of tibial nerve compression. So focal nerve area of pain, that's the one that's going to get us to a stress fracture. When you can get that one area, doesn't hurt, doesn't hurt, doesn't hurt. Oh my God, it hurts, doesn't hurt, doesn't hurt, doesn't hurt. That's indicative of stress fractures. All those other options, frequency of exercise depends on the patient. Pronated foot posture not really related, not super correlated to medial tibial stress syndrome. And symptoms of tibial nerve compression, that would be nerve compression, not so much a stress fracture. So focal area of pain is the best one that gets us to a stress fracture. So this question illustrates you need to know your prognosis and you need to know what findings are most prevalent with certain conditions and what we can use to rule them in and rule them out. Our last question asks us about treatment. Treatment for medial tibial stress syndrome should begin with what? So we're asked about should begin with what? We're just starting here because we have hip strengthening, relative rest, stretching of the soleus, use of a shin splint strap. You might be thinking all those are appropriate, but the question is asking what should we begin with? If we're concerned about stress fractures, medial tibial stress syndrome, relative rest is what we want to do. So that is our best choice. And in terms of the timeframes, it's going to depend on how the patient presents and what activity they're doing. But relative rest is what we want to do initially. We want to counsel that patient to rest, and then we're going to go from there. And some of those other options, like I said, might be in your plan of care, but not initially. So it's important to pay attention to what the question is asking and when the question is asking. If this condition said the patient has progressed and done very well, and now it's 2 months later and their pain has diminished and they've given you more findings, one of these other choices might be more appetizing. So pay attention to that. So hopefully this scenario gave you some information about paying attention to the age, paying attention to the activity that someone does, what condition might be present, and we have to be aware of the etiology of that condition, the differential diagnosis, and what are some findings that may help us rule in or rule out that condition. So that's important to know for all our conditions, and hopefully this scenario kind of drove that home for us.